So we performed the Absorb-3 pivotal randomized trial in 2008 patients in which we randomized patients with routine coronary artery disease to receive either the new Absorb bioresorbable scaffold versus a standard best-in-class metallic drug-eluting stent. Bioresorbable scaffold is made of a polymer. It's made of poly-L-lactic acid, and it elutes everolimus. And the concept is within the first year, it provides the mechanical support functions and anti-proliferative drug elution capability of any other metallic drug-eluting stent, but then it goes away. It dissolves by 3 years, and it restores the vessel to its normal underlying state. So it can have normal vasomotor tone, it can have normal vascular adaptive responses, etc. In this large randomized trial, which was intended to support approval of this device in the United States, we found similar rates overall of most endpoints at the end of 1 year between Absorb and Xience, not statistically significantly different. So the primary endpoints of the trial were met. But there were some concerns towards a signal to increased stent thrombosis or scaffold thrombosis with Absorb compared to Xience. It wasn't a statistically significant difference, but the rates tended to be doubled. So we looked at all the standard subgroups to see if there was one in which the event rates seemed like they were clustering, and we couldn't find one. And we then went ahead and looked at a specific subgroup of patients who were treated with very, very small vessels. And we were supposed to treat vessels that had a reference vessel diameter of 2.5 millimeters or larger. But we actually found that 19% of patients had treatment of a lesion with a reference vessel diameter by quantitative coronary angiography that was smaller than that. And that's a real concern because the struts of this first generation scaffold are thicker than the Xience stent. And if you put it inside a really small vessel, smaller than what it's intended, then you've got a lot of material with thick struts in a small vessel that you're cramming it in, and that could lead to increased turbulence and platelet deposition and greater scaffold thrombosis. So when we looked at the outcomes in that subgroup, sure enough, we did find that's where most of these adverse events clustered. And the scaffold thrombosis rates were 4.6% in those very small vessels, compared to 1.5% with Xience. In contrast, in the patients who had good-sized vessels treated, the kind that the device is intended for, that was most of the patients, then the scaffold and stent thrombosis rates were almost identical and were very, very low. So what this really suggests is that if you treat the appropriate patients with this new bioresorbable scaffold, which we expect to be approved by the FDA later this year, that you can get 1-year outcomes that are similar to Xience, one of the best metallic drug-eluting stents, therefore affording a good safety profile to allow the long-term benefits of the scaffold once it dissolves to appear, which will take up to 5 years or more. In contrast, you should really avoid treating these very small vessels with the scaffold, so use advanced imaging techniques or other ways of making sure, if you're on the borderline, that you don't treat very small vessels with this new thicker strut device.